Good evening, everyone, and welcome to another edition of LEJ Endo, the Lister Endometriosis Journal Club. We are almost 2 years into the LEJ Endo sessions, and we are planning to continue every month at 6 p.m. UK time on the 6th of each month. Regardless of what day. So today it's a Sunday. I know, you would prefer to do other things. But thank you for joining us. Thank you for being here. A couple of things to say before we start. First one is that this program is supported by Karl Storz UK and in collaboration with EEL, European Endometriosis League. What we say and what we present does not necessarily reflect our views as a team. And the team that runs this journal club, in fact, you can see most of them now, if not all. We have Mikey Adamczyk, my consultant colleague, and Ben Mondelli, my other consultant colleague, as of last week. And then Flo Britton is the CMIC's current fellow, Kyle Fleischer and Avril Bacci are the previous fellows. And together they sift through quite a lot of articles and find the most relevant ones and interesting ones for you. And we also have the pleasure of having Dr. Gabor Csaba from Hungary, Semmelweis University. I met Gabor recently. I have known of his name, but I don't think I've had the pleasure to meet him. But I listened to his talk at the EEL meeting in Bucharest, and I thought that was one of very few excellent talks and refreshing talks that I've ever listened to. I was very excited, lots of new information, things that I didn't know, and that was amazing. So I'm very grateful that Gabor has invited our invitation, and today he will be our featured presenter. Welcome, Gabor.
Hello, everybody. Thank you, Professor Kazali. Thank you, Shaheen, for the kind invitation, and it's a great honor and pleasure to be part of the Lister Endometriosis Journal Club.
Thank you very much. Thank you for being here. So the way this usually works is that we start with one or two or sometimes three small article presentations. Then our featured presenter will give his talk, and then we continue with two or three more. If you have any questions, if you want to discuss anything, please use the Q&A button at the bottom. So, Avril, the floor is yours.
Okay, good evening, everyone. Thank you for joining LEJ Endo this evening. So my first paper, Flo, you're controlling the slides, isn't it?
Yeah.
Oh, cool. Thank you. So my first paper is from a team from Lille in France. Flo, can you go to my slide, please?
That moved?
No.
No, not for us.
Yeah.
Yeah, so this first paper is by a team from Lille in France, and the main aim of this study was to evaluate the impact of deep endometriosis surgery on the bladder function and the possible impact of the surgical resection. So next slide, please. So they included all studies which evaluated urodynamic studies on women affected by endometriosis before surgery. So out of their literature review, they included 9 studies, which included 574 women. 3 of these 9 studies were from Brazil, and the rest was from Europe. And all of these studies, apart from one, was a prospective design. 6 out of 9 of these studies did compare urodynamic findings before and after surgery. The post-op follow-up for these studies were varying between 3 months to 1 year, which the authors do mention is one of the limitations of the study. Next slide, please. So I will go through the main findings of this study. So the first one, in terms of preoperative finding, 7 of these studies mentioned that the Truser overactivity was reported in 15% of women with deep endometriosis. As you can see here, the I square and H square quite high, telling us that there is a lot of heterogeneity in the studies, in all these studies, which the author is also mentioning as one of its limitations. Next slide, please. And in terms of voiding dysfunction, this was seen in 21% of the population. And next. And in terms of low maximum cystometry capacity, in other words, low bladder capacity, this was seen in 18% of the patients. And next slide. And 3 studies evaluated the presence of abnormal bladder sensation, and this was found in 39 of the patients. And next. And yes, and in terms of studies which compared pre and post-operative findings, there was no difference between the pre-op and the post-op urodynamic detrusor overactivity, which was seen in 4 of these studies. And the next one, and there was also no difference in the pre and post-op voiding dysfunction that was reported. So what the authors wanted to conclude was abnormal urodynamic findings before surgery are prevalent in women with deep endometriosis, and surgery does not seem to affect the outcomes of urodynamic studies. However, there is a large heterogeneity amongst the studies, and this may limit generalizability of our findings. And that's it for me.
So urodynamics abnormalities, particularly overactivity of the detrusor, is more common than the general population pre-op, and it doesn't change post-op.
Yeah, there was no significant difference in the finding.
Okay. Well, that's slightly different to the finding of some other studies that do show problems with bladder function after. I mean, some of our colleagues report up to 15% of retention. We get retention from time to time as well. I think it would be interesting to see a better study, a bigger study perhaps, to see what really the answer is to the question of urinary function as a result of deep endometriosis excision. Okay. Is that yours now, Flo?
Yeah, yes. So the next paper that I've got here is due to be published in JMEG. It was accepted just last month. This was an interesting paper carried out by a group in Texas. Well, it was a surgeon and their 2 fellows, and they looked to assess the surgical enhancement of the placement of temporary bilateral ureteric stents with ICG for all stages of endometriosis in V nodes. And this was a retrospective cross-sectional study. So the inclusion criteria for this study were all patients who underwent V nodes for endometriosis excision between September 23 and May 24. They included 50 patients, all of which who underwent a total hysterectomy. As I said, it was performed by a single MIGS fellowship trained surgeon and their 2 fellows in a tertiary centre for endometriosis referral. The surgical technique that they used, so they used a 17 franc sheath cystoscope threaded with a single 5 franc open-ended 27 centimetre stent. They mixed up 23 milligrams of ICG with 10 mils of normal saline, and then the stent was inserted 15 centimetres retrograde into the ureter and 5 mils of the solution injected. They then allowed this temporary stent to sit in that ureter for 60 seconds before withdrawing it and then repeating on the contralateral ureter, again injecting 5 mils. The time it was taken for the surgeon to perform this was recorded for the results. And then moving on to the second part, so once they were in the pelvis and the robot was docked and the pelvic sidewall was visualized, they then recorded the time taken for the primary surgeon to visualize the ureter vermiculate. The maximum time for this was 240 seconds. So if the surgeon hadn't identified the ureter at this stage, the ICG was then activated, or the infrared was switched on. So the time recorded then to visualize the ureter after the ICG was activated was then recorded. So moving on to the results. So the median time to place both stents with the ICG injection was 229 seconds. And then you can see from the table, the time taken for the surgeon to identify the ureter without the ICG was 17 seconds, both on the left and the right pelvic side wall. And then with ICG, it was recorded as 1 second. And then at the surgeon's discretion, they could use the near infrared to activate, to see the ICG at different points in the procedure, whether they're doing difficult dissection around the ureter, to identify the ureter with bleeding. And the number of times that they activated this was counted throughout the procedure. And it was shown to be used 12 times on the right side of the pelvis and 11 on the left. So just following this sort of pilot study carried out in this center in Texas, they now use this temporary stent placement in ICG as standard practice for all patients undergoing robotic V-nodes. The strengths of this study, so it's an innovative approach. It allows fast identification of the ureters, and it may be reproducible widespread for other pelvic procedures. I guess limitations to it, it was only done in a single center, and the sample size was relatively small with only 50 patients. Whether the cost effectiveness of it as well wasn't addressed in this study, and also the long-term outcomes, whether there's any ureteric trauma, for instance. But in conclusion, the authors did conclude that this surgical technique has advantages over traditional techniques in that it's perhaps reduces risk of ureteric injuries by providing clear identification of the ureters, even in very difficult distorted anatomy. The ICG has the ability to bypass partial urethral obstructions, and it may cause less ureteric trauma. They pose that actually using prolonged lighted stent may cause urethral strictures or epithelial damage, which this technique does not. And they believe that it may benefit less experienced surgeons during complex endometriosis surgery.
Okay. I have so many questions.
So many.
Who's that from Jan Einarsson? And yes, okay. I mean, it would be interesting because I'm actually not familiar with how endometriosis surgery can be done through V-nodes. But Jan Einarsson is a very experienced surgeon. I'm sure that's doable, but I just can't picture it that if you're going through the vagina, can you really deal with severe endometriosis? How would you do that? But I'm probably that's probably my ignorance. I don't know if you guys know more.
It's quite impressive if I can put bilateral stenting and ICG injection in less than 4 minutes, though.
That was my comment, really.
Well, it depends where you start the timer, and I don't know if the time matters really. I think this is first of all a note for Kyle, Flo, Avril to see how you can get a publication out of your everyday procedures. So they putting ICG up the ureters has been used for a long time now. There's nothing new there. And then measuring the time, I don't know what you're measuring from what point, if you counting the time that it takes to actually prepare the cystoscope, clean, go in. But that doesn't matter if a step helps you perform a procedure more safely. It doesn't matter if it adds to the time of the procedure. And then yeah, so that part is not my question. The other strange thing that it's not strange. I should read the paper to be able to comment, but all patients had a hysterectomy. I don't know. So was the indication need for hysterectomy? If so, why are we talking about endometriosis surgery? It's I
Another
don't know.
question would be nice to know, like, did ICG then help avoiding having to do ureterolysis, or?
And sorry, when I looked at the paper, was I looking at the next paper? And yeah, okay. So who was this paper published by? So who are the authors for the paper you just presented?
So this was by Lavelle.
I take it back. If Jan is listening, I now realize that's not your paper. I'm not criticizing the paper. I haven't read it, so I can't criticize it. But yeah, for a second I thought that's coming from Jan. Okay. Well, an interesting one to read, but my questions would not actually be related to what the paper is trying to say, which is, okay, you can put ICG up the ureter, of course, but we've done this for a long time. The time, it doesn't really matter in my opinion. You know, if you are used to doing cystoscopies, then you'll find the ostia within seconds. I get that. But anyway, all right, let's move on and go to Gabor Jabo. Am I saying it right? Is it Shabo? Oh, you're on mute, I think.
Your pronunciation the first time is Sabo was perfect. Yeah.
Sabo. Okay.
Sabo. Yeah.
Sabo.
Family name.
Okay,
So I
Gabor.
just start to share my screen.
It's a pleasure to have you. I'm going to close my camera and the floor is yours. By the way, we have very good turn up today, even though it's a Sunday,
Sorry?
or maybe because it's a Sunday. So thank
Sorry,
you
can you see my?
for being here. I think it's trying to. Double click to enter full screen mode. Try again. Yeah, we can see you now.
You can see my presentation. Perfect.
Yes.
So today our topic will be the visualization of the sacral nerve roots and the sacral plexus and originating from the sacral nerves from S1, S2, and also joining the lumbosacral trunk for L4 and L5. And they are running anterior to the piriformis muscle, just leaving the pelvis through the greater sciatic foramen. Most nerves under the piriformis muscle, under the infrapiriform hiatus. And two vessels are stitching through the sacral plexus. The one of them is the gluteal superior artery. On the image you can see on this dissected pelvic area, the AGS is marked with the superior gluteal artery. And this is the vessel which goes upper above the piriformis muscle. And under the and between the S2, S3 nerves, the inferior gluteal artery is running. And so this is the region where the sacral plexus is located in the posterior pelvic sidewall and then the posterior parametrium. This plexus has both somatic and vegetative functions. And somatic innervation means in the motoric way, the muscles and the posterior part of the lower extremity, the sort of flexor muscles, but also the extensor muscles in the crus and also the feet. And the innervation of the cutaneous, the nociceptive innervation means also the thigh, the posterior part of the lower extremity, the feet, and the anterior part of the crus. Also important, the vegetative innervative
I'm sorry,
function.
Gabor.
Yes.
Interrupt. Can you turn your camera on? Because it would be nice to see you as you're presenting.
Just a second. Okay. Can you see me?
Thank you very much. Yeah, that's perfect.
Perfect. Thank you. Sorry for the inconvenience. So the visceral function coming from the sacral plexus are the parasympathetic and visceral innervation of the pelvic organs like the bladder, the rectum, also the cervix. And these parasympathetic viscera branches are originating from the anterior division of the S2, S3, and S4 spinal nerves. And these nerves are just joining to the sympathetic part to the inferior hypogastric plexus coming through the hypogastric nerve. And this is the area, if we move forward, that the sacral nerves are just joining together to the inferior hypogastric plexus. And meantime, in the last 15, 20 years, ultrasonographic visualization of the peripheral nerves and the superficial curves is just usual in the daily routine, for example, in orthopedic or neurologic neurosonographic diagnostic. And those peripheral nerves are having typical, in longitudinal section, a typical bundle of straw appearance. And these white hypoechoic areas are the epineurium, the inner and the outer epineurium. And between the epineurium, we can see this hypoechoic bands, and these are the nerve fascicles. If we look for the transverse section, the echotexture of the nerves are a honeycomb shaped. And firstly, a deep endometriosis nodule, which was infiltrating outside of the pelvis on the sciatic nerve, was diagnosed with a transgluteal approach in our department, in our university, at the neurological department by Professor Parani. And she described that deep endometriosis lesions are hypoechoic, and they just damage this bundle of straw appearance on the sciatic nerve. However, the deep endometriosis nodules and the sacral plexus in the pelvis, and the sacral plexus is located very deep anterior to the sacrum, so it's not accessible with transabdominal or transgluteal approach. And previously, it has been assumed that pelvic nerves, also the sacral plexus, cannot be visualized with transvaginal ultrasonography. So our aim was to describe a method for the visualization of the normal sacral plexus during a standard gynecological transvaginal examination. We wanted also to perform a standardized measurement of the sacral plexus with TVS. And we wanted also to define the influencing factor during the visualization of the SPs, TVS, so which are the positive and negative influencing factor. And in the next images, I will show you the 6-step protocol we described in our article. At the first step, the transducer was placed in the anterior vaginal fornix. So we wanted to show in the medial sagittal plane, the cervix, the uterus, and the endometrium cavity in the longitudinal view. As you can see also in an intraoperative image, the asterisk shows the place of the probe in the anterior vaginal fornix. And at the second step, we rotated at the level of the inner cervical meatus the probe. So we obtained the transverse view of the cervix marked with C. And we also see in this image with asterisk, the white asterisk and the ultrasound image, we can see the uterine artery. And just immediately at the third step, we moved the transvaginal probe in the lateral vaginal fornix near to the uterine vessels, and a little tilting just following behind the uterine vessels to find a hyperechoic thick band, the uterosacral ligament, marked with S on both the sketch and the images. So this uterosacral ligament is going from medial to lateral in a semi-horizontal way from the cervix to the pelvic lateral side wall. And most of the pelvic side wall is covered with the obturator internus muscle, marked with O on the sketch and on the ultrasound image. And this is in longitudinal view is a hypoechoic band. And lateral to the obturator internus muscle, there is this white bright line, which corresponds to the body of the ischium. So just lateral from the obturator internus muscle, with black arrow, you can see the body of the ischium. And if we follow these structures, I mean the obturator internus muscle and the body of the ischium posteriorly, where they ends, we found the greater sciatic foramen marked with the black circle. And there we can see vessels going through the greater sciatic foramen on branches of the anterior division of the internal iliac vessels. These are marked with the white arrows. And also some hypoechoic muscle bundle fibers with some hyperechoic perimysium. This is the marked with P, the piriformis muscles. And we also see behind the muscle, the ala of the sacrum. This is the white bright line behind the P, behind the piriformis muscle. And if we look between the vessels and between the piriformis muscle, we can see the bundle of straw appearance of the sacral plexus marked with the black arrow. You can see on the intraoperative image with the black asterisk that the probe is already in near contact with the pelvic side wall. If we go further, we used the color Doppler, and color Doppler is helpful to track the anterior branches of the internal iliac vessels back to the branching where the posterior division also starts. And this is an important place because then you can see with the black circle that the S1 nerve between the anterior and the posterior division of the internal iliac vessels are located. And from the posterior branch of the internal iliac artery originates the superior gluteal artery. And if we follow the superior gluteal artery, it goes just above the piriformis muscle. You see with white arrow and the intraoperative image, both on the intraoperative image and then the ultrasound image. And it will validate that you have followed the right vessel because this is the only vessel which leads the pelvis above the piriformis muscle at the suprapiriform hiatus. At the sixth step of the protocol, we also followed the previously mentioned S1 nerve root, the first sacral nerve root, proximal to the anterior sacral foramen, marked with the dashed line circle. And we can even meet at that point with the white asterisk, the sacral lateral artery. For a better understanding, I would start with the next 2.5 minute video where we can see the scan and the sixth step protocol. This is the second step at the inner cervical meatus, as we have seen the uterine vessels. And behind the uterine vessels, we can see the white hyperechoic band. This is the uterosacral ligament coming from medial from the cervix to lateral to the pelvic lateral side wall. You can see the hypoechoic area, the band, the obturator internus muscle almost perpendicular to the uterosacral ligament. And on the lateral side of the obturator internus muscle, the white bright line, the ischium. We follow them now, the obturator internus muscle and also the ischium back to the greater sciatic foramen. You can see the dotted line circle. You can see also with grayscale how the anterior branches, the branches of the anterior division of the internal iliac artery running at that area. And one main branch will be the inferior gluteal artery. And you can see also the piriformis muscle. So, and a white bright line behind the piriformis muscle will be the ala of the sacrum. So this was the fourth step, and this is the place when we will measure the sacral plexus, and this is the diameter from the most inner part of the obturator internus muscle where we measure the cross-section of the sacral plexus. That's what the standardized measurement. If you see now the cross-section after the rotation, you can even imagine how the honeycomb echo texture looks like in cross-section of the nerve. And as the sixth step, or the fifth and the sixth step, we just follow back the sacral plexus and the first sacral nerve to the anterior sacral foramina. Color Doppler helps us to trace the inferior gluteal vessels from lateral to medial. We just follow, you can see also the bundle of straw as it's running parallelly to the our vessels. And one branch from the internal iliac artery from the posterior division is the sacral lateral artery. It goes also through the sacral artery or sacral foramina into the sacral canal, and you can see between the base and the ala of the sacrum the anterior foramina. This is a nice part where you can identify the bundle of straw ecotexture in longitudinal section of the nerve. So this video showed also the 6-step protocol. And if we go further in our application, we also presented firstly the how intraoperative the sacral plexus looks like. We filled up with saline infusion the abdominal cavity during the operation. Professor Bokor and Professor Hudelis made the laparoscopy dissection, and I performed the scan. And you can see in the image how the califorceps was placed on the nerve. You can see also with asterisk the swab, how it looks like during the operation and during the laparoscopy, during the intraoperative ultrasonography. And the white circle shows the nerves and the bundle of straw appearance of the sacral plexus. So in our feasibility study at the Semmelweis University Budapest, at the Department of Obstetrics and Gynecology, during this 14 months in this prospective randomized observational study, we scanned 326 consecutive patients. 2 operators performed the scans. My young colleague István Madár, more than 5 years experience with gynecological ultrasound, and myself more than 20 years of experience. And so we had 2 operators, and the primary indication you can see on the table why the ultrasonography performed by the patient. And the results at the next table, so about 1/3 of the patient had a normal pelvis, but also there were also some fibroids, ovarian cystic lesions, also deep endometriosis were presented, and also some cases with tight ovarian adhesions and obliterated pouch of Douglas. And our research shows that in all women, the sacral plexus was identified successfully at least on one side. However, both sacral plexuses were also identified more than 97%. And the visualization time was at that time on both sides 9 seconds. And the standardized measurement at the right side was 15 millimeter and the left side and 14.9 millimeters in the cross section. Don't worry about this table. The main influencing, the influencing factors which affecting the time needed to visualize the sacral plexuses are visible, and 2 negative factors were found. One of them was the pelvic pain, and the other was the pelvic deep endometriosis. And there was another factor which helped to find the sacral plexuses in a short time, and it was the experience which was gathered during the scans. We made 2 epochs during the study. The first half of the study, the length of the visualization time was longer than in the second half in both operators. If you look for the factors which significantly affected the length of time needed to visualize the sacral plexuses, we found that pelvic pain and pelvic deep endometriosis were the 2 main negative influencing factors. In that cases, more than 50% of the patients, more than 9 seconds were needed to visualize the plexuses. So we can conclude after our study that we just established a novel method with transvaginal ultrasound for the consistent and rapid identification of the sacral plexus. And also a standardized measurement was performed, and it's possible with TVS. And the 2 factors which were significantly affecting the length of time needed to visualize the SPs were pelvic pain and pelvic deep endometriosis. You can ask me why it's important to find the sacral plexuses with transvaginal ultrasonography. I think our study group believed that we could establish a new field of ultrasonography about pelvoneurosonography. So the ultrasound examination of the pelvic nerves, which can help us to map pelvic deep endometriosis lesions in the posterior parametrium and the pelvic sidewall, which can affect the sacral plexus. And in the last years, we also presented the clinical and ultrasound characteristic of deep endometriosis affecting the sacral plexus. And we are very grateful because the IDEA group also involved our technique in the addendum of the IDEA approach for the parametrium. And we also believe that identifying the pelvic retroperitoneal benign nerve sheath tumors as possible with the previously mentioned technique. We work together with Professor Daniela Fischerova and other colleagues from Philippines and Italy, and they also we presented a paper in that topic. And a very new paper just accepted last month in the White Journal about the pelvic sidewall. And I think that some gynecological tumors which can infiltrate this area, like cervical cancer and endometrial cancer, are also important, that it can be visualized with transvaginal sonography. And last but not least, with Professor Hudelist and Professor Bokor, we are also just submitting an article about the piriformis muscle and about the importance of transvaginal scan in piriformis syndrome. This paper is now under submission. So thank you very much for your kind attention. And I just want to thank all of the colleagues and in our group, Professor Attila Bokor, Professor Gerno Hudelis, István Madar, and all of our fellows who contributed to our work in the last years. I give back the word, stop the sharing. If you have any questions, I'm ready to answer.
That is really, really interesting. It just opens a lot of doors. I have a few questions, but let's first answer the question that has come from the audience. What is the measurements for? So you said that you would measure the sacral plexus diameter. What does that tell you?
Yep, I think this is a situation where we have a normal measurement value. Previously, it wasn't made because it's not so easy to measure something like a plexus. There are branches, there are connecting branches between them, and we wanted to find a place where the plexus is still in the pelvis. However, the main branches like the pudendal or the sciatic nerve is just not already divided. And we can tell if the deep endometriosis later will affect or just infiltrate the nerves. Will it be maybe changing during the disease or due to the pathology?
Okay, but do we know the normal sizes already? Are there reference sizes at the moment?
The problem is that we have only MRI or cadaveric specimens. However, with MRI, it's not so easy to measure the diameter of the sacral plexus because MRI will give us orthogonal planes, and these nerves are mostly oblique. And with transvaginal scan, we have the opportunity to measure the correct transverse section of the nerve, not only an oblique one like with MRI, because the nerve is going from anterior to posterior, medial to lateral, and also from superior to inferior. So it's not correct measurement if you just measure it in a sagittal plane or in a transverse plane. And with cadaveric, I think we don't know how it changes because of the freezing or because of the conservating. It surely changes the diameter. But this is an in vivo measurement and non-invasive in vivo measurement, and that's why I think it was important to measure the normal value of the sacral plexus in a standardized location.
Okay. Mikey, do you have any comments, questions?
No, I was just thinking that the size is actually really important, what you've mentioned, Shaheen, because that could also indicate compression of the nerve, right? But I'm really sort of intrigued by this presentation. I think it's great, and I think it's particularly good for not only for endometriosis but also for vascular compression of the sacral nerve roots, and presumably that's something that you can see quite nicely on a ultrasound scan. So what's your experience with vascular compressions?
That's a very good question, Mikey, because I think this is our next topic. Already have patients with that. Vascular entrapment, vascular compression, as you mentioned. It's very interesting because those patients who had such situation have similar symptoms like with deep endometriosis affecting the nerves. However, in the anamnesis of the patient, there are mostly some previous pelvic infection or I mean pelvic inflammatory disease, or maybe the patient had during the delivery a placenta retention, and she has some curettage, so there was maybe a puerperal phlebothrombosis in the pelvis, or the patient had because of deep endometriosis or other indication, complicated hysterectomy. And those adhesions, those infections, just closing some part of the vessels coming from this area, from the obturator, the gluteal, or the parametrial vessels. And some other vessels like anastomosis, they will be more dilated, and they will compress these nerves. So this is our experience with that, but they are clearly visible with ultrasound with color Doppler.
Because on MRI, Shaheen, your experience is probably very similar, that they can be quite difficult to diagnose. We can see endometriosis quite well on MRI, on the pelvic nerves, but sometimes vascular compressions can be tricky and used most of the time as a clinical
and I think that's what the ultrasound scan can add, because you can put a Doppler on and you can see the diameter of the vessels, particularly in pudendal nerve compressions.
I agree with you, because pelvic congestion syndrome, there are some diameters about parametrial veins which are more than 9 or 10 millimeters. However, I think there are very experienced colleagues who do not think that pelvic congestion syndrome is a real disease, but after this experience in the last years, I think that there is really some interesting point to look for these for the anamnesis of the patient and looking for these dilated vessels if they are just running in close contact with some of the branches of the sacral plexus, because this can be how to say, answering the questions and the symptoms of the patient.
Okay, so Alvaro is asking a question which I suspect is my question as well, about the learning curve. And just tell us how you learned it, although you did touch on it. But you came from a place where you already had quite a lot of experience. So what would you say could be a learning policy? Yeah, go on.
Shane, sorry, I have about a 5 seconds audio pause. Could you repeat the question again?
Yes, about the learning curve.
Okay.
How would you suggest that somebody like me, I do scan, I can see bowel endometriosis, but I've never looked for nerve endometriosis. How would you recommend that I learn this?
I think in the last 1.5 years, many colleagues from centers visited our department. And I think those colleagues who had already experienced maybe deep endometriosis in a 2-day manner. So in a couple of patients, I think maybe 10, 15, they just really learned how to do it. For those colleagues who are not so experienced, we are running now at the moment a multicentric learning curve study for that purpose, to see how many examinations are needed to make a stable knowledge and skill, learning the skill. But I would focus on those lesions which are involving the parametrium and the uterosacral ligament and just reaching the pelvic side wall. And it's also very important that we did not have any patient without symptoms. Without symptoms like dysesthesia, paresthesia in the lower extremity, or just radiating in the perineum, or some of the patients had also urinary problems, like urinary incontinence. Low numbers, but also presented. So I think symptoms of the patient looking for big uterosacral and parametrial nodules in the hashtag NCMB compartment, because the lesions, the lowest diameter of the deep endometriosis nodule in the location which affected the sacral plexus was 2 centimeters, but the median diameter was 3.5 centimeters. So big nodules in the uterosacral ligament and the parametrium with symptoms.
Okay. I can see Pauline Callahan's hand is up. I don't know, Pauline, if you want to type your question or you want to speak. Let me see, or maybe the hand up has gone now. Okay. Well, that's really, really interesting. So maybe I should come and visit you and learn this. This is really exciting, really interesting
It's
to
more,
me.
you are more than welcome to come, and to tell the truth, we will have next month the European Endometriosis League ultrasound cruise in Budapest. I think it's already fully booked, but maybe next year will be also repeated. But if anybody want to visit us, really more than welcome.
Okay. Okay. I
Can
know
can I
people in high places. Maybe I can pull some strings. Okay, thank you very much. Again, it's really lovely to have you, and thank you for your time on a Sunday. Okay, let's go to our final two presentations. And Gabor, if you would have another 15 minutes to stay with us, just in case there are other questions, or if you have any opinion regarding the papers that are being presented, that would be great.
Absolutely, thank you.
Okay, so who's going next? Is it Avril?
Yes, I'm going next. So the next paper that I will be talking about is from a team, so from Professor Jon Einerson's team in Boston, Massachusetts. And the main aim of the paper is to examine the outcomes of surgery performed for bowel endometriosis. And this includes shave, discoid resections with hand-sewn closure, and segmental resection. So next slide, please. So this is a retrospective study. They included all patients who underwent surgery for bowel endometriosis between 2009 and 2022 at the Brigham's Women's Hospital and the Women's Faulkner Hospital, both located in Boston. So these are the patient characteristics. So 82 had shave, 23 had discoid excision, and 7 had segmental resection. For all discoid excisions, they were performed using hand suture, whereas the segmental resections, all 7 were performed using a staple device. Looking at the lesion size on pre-op imaging, the mean size of nodule for shaving was about 20.7 millimeters. For disc, it is 23 millimeters, and for segmental resection is 38.5 millimeters. In terms of repairing the layers, so with disc excision, the authors always repair it in 2 layers, and sometimes they would add a 3rd layer if they feel that it's required for a more secure closure. And additionally, they use a fat flap that is created from the adjacent fat of the lateral border of the bowel, and this is sutured together over the closure of the bowel to allow a better seal of closure and to reduce the risk of leakage, even though the author do admit that there hasn't been studies used to prove it. In terms of shaving, in some of the cases, the shaved area was also repaired in either 1 or 2 layers. And with shaving and discoid excision with this closure, the suture material used were either monocryl, barbed suture, or both. But again, the authors did not mention what were the indications for whichever type of suture. So in terms of the Clavin-Dindo complication, 4 cases of 3B in the shave, 2 in discoid, and 0 in segmental resection. In terms of reoperation for bowel perforation, which they mean by anastomotic leak, there was about 3%, 3.7% in the shave group. And in the text of the results, they said that there was 1 in the disc excision. However, in this table, it mentions 2. So then 8.7% in the disc group. And the author compared his result with the recent meta-analysis that was performed by Professor Bendifala. That was done, I think, 3 years ago. And in terms of the leak rate for shave, disc, and segmental, they were about 2.2%, 9.7%, and 9.9%. So that was what the meta-analysis showed, and they compared their results to that. Next slide, please. They looked at also the risk of Clavin-Dindo complications with the different layers of bowel closure and the types of sutures that were used, and they did not show any significant difference, although this study was not powered to do that. So the conclusion that they gained from this study was that the number of so their data showed a similar leak as compared to the literature. And whilst the study is underpowered, these findings do support hand sewing for discoid excision is a safe and reasonable alternative to a circular stapler closure. But do admit that this study has some limitations, which is its retrospective nature, small number of cases, and advocate for a larger prospective study to validate these findings and to provide a more robust evidence supporting the efficacy and safety of hand sewing in discoid excision. And that is all for me.
I don't know what is the level at which you say this rate of reoperating is too high. I don't know. So 8.7%, I think it was, or 10 point something. Go back one. So the hand-sewn discoid excisions had 8.7% leak, basically. Is that correct?
So there was one thing that was a bit confusing with this paper. So in the table, it says 2, but in their text with, in terms of the results, they mention 1.
Yeah, but I think if we're looking at this table, judging by this and the percentages, I'm not sure. I know that rates up to this has been reported, but I have a feeling that perhaps 8.7% leak is a little bit too high. And did they explain why they don't use transanal discoid?
As in a stapler, no, they didn't. It's just that in their introduction, they said that the use of staplers might pose challenges in terms of cost and availability, but did not mention why specifically they used hand sewn instead of the stapler.
Okay. Well, anyway, it's very good of them to publish this data. It's interesting. It adds to the body of evidence. I think, again, Flo, this may be a paper for you, you know, just looking at your our discoid. I think we should by now have more than 100 discoid excisions. And I know that we have had 0 leak so far, touch wood. Okay. The other thing to mention is about number of layers. More layers doesn't necessarily mean better protection. More layers actually means ischemia. I don't know if anybody has any opinion about that, please share. But to me, one layer done well, I think is I think Gernot is agreeing here as well that 8% lead suture very high. This conclusion is not justified unless they have been ultra low. I think maybe at least the wording could have been better, because you can only say this is safe if you really consistently in a large number show complication rates lower than the published result. Yeah, I agree. In my books, 8% is too high. But anyway, it may have been ultra complex cases, so it's difficult without me reading it properly. Hi, Gernot, by the way, thanks for being here. Okay, the last paper.
Okay, so the final paper is another paper which is awaiting printing in fertility and sterility. This was carried out by a group in Sweden, LEJ Endo, and the group looked to investigate the morphological and size changes in endometriosis during pregnancy and also after delivery using ultrasound. So what were the key questions that this study group wanted to answer? So they wanted to know how endometriomas behave in pregnancy, including morphological changes, cyst type, cyst content, presence of solid components, and the size. Do they grow, shrink, or remain stable? Quite unique to this paper, it looked in the postpartum period as well, and it also focused on deciddualization of the endometrioma. So that's the development of solid components in the endometriomas, which we know that does have the tendency to mimic malignancy with those solid components and vascularization. So moving on to methodology, it was a prospective cohort study, included 57 women, all that had endometriomas, and they were cared at Skane University Hospital in Sweden between 2013 and 24. So these women were offered monthly scans throughout their pregnancy and then 3 months and 12 months postpartum. It was a combination of both transvaginal and transabdominal ultrasound, but as you can imagine, in later gestation, actually accurately visualizing the adnexa becomes less possible. The endometriomas were assessed on 3 orthogonal planes according to terms and definitions of IOTA. And then they report the deciddualization, as I said, as the presence of solid components or papillary projections that often have a moderate or rich vascularization. Just looking at this demographic data, you can see there was a mix of nulliparous and parous women. Interestingly, over 1/3 of women didn't know they had an endometrioma prior to their first scan in pregnancy, and the average number of scans they had throughout the pregnancy was 4. Postpartum, the uptake was relatively good. 94% of women had a scan following delivery. That was 70% at 3 months and 65% at 12. So going on to the results, so there was morphological changes in the endometrioma seen in 74% of women and deciddualization in 58% of these endometriomas. And interestingly, they showed that there was no difference in the women who had morphological changes and didn't with regards to their age, parity, and whether they had ART. So you can see from this first figure that actually 74% overall, 74% of endometriomas decrease in size in pregnancy, 11 increase. So that leaves 15 that remain stable. And following delivery, 26% of endometriomas completely resolved. So another figure shown here just nicely visualized, shows a visual of that endometriomas reducing in size as you go through the gestation and postpartum. But conversely, in figure B on the right, you can see that actually the size of the largest component of the endometrioma actually increases, and this comes from about 22 weeks gestation. The study reports deciddualization occurring in 58% of cases, but these signs disappeared following delivery. So what's the clinical relevance of this? As I said at the beginning, deciddualization may mimic borderline malignancy, so it's important to recognize this change in endometrioma to prevent any misdiagnosis of these women that may lead to further unnecessary interventions. So strengths and limitations of the study, it reports to be one of the largest cohort studies looking at endometriomas in pregnancy, although it is still relatively small with 57 women. It's prospective in design. But as I said, the limitations include not being able to fully assess the adnexa in later stages of pregnancy. And also this diagnosis was only based on ultrasound. There was no histological confirmation of endometriosis. So to finish, the takeaways from this paper, 3 out of 4 endometriomas will undergo morphological size during pregnancy, and we know that this is mediated by sex steroid hormones. We know there's an increase in both estrogen and progesterone, but it's actually the balance of in favor of the progesterone that is most likely causing these changes. The study group speculates that it's actually the rise in the progesterone that stimulates the solid components, but this is just a hypothesis, it hasn't been proven. But it's important to, as I said, recognize these changes to avoid any overdiagnosis of women with endometriosis and a benign disease.
Okay, well, thank you very much. Alvaro, your hand is up. Do you want to say something?
I think there was a question from Alvaro asking if
The
Flo
size of
mentioned the size of
endometriomas, did
endometriomas.
they mention the size? Flo?
Yes, they did, and they said that a significant increase or decrease in size was 6 millimeters. So, well, maybe I should have included that table, but it was a complete spread of sizes, and there was bilateral and unilateral endometriomas.
Okay. Well, thank you very much. It's 5 minutes past, so we're going to close and thank Dr. Sabo again. We have for our next month Professor Booker, who is going to present the randomized controlled trial on nodes. Am I right? Yes, natural orifice extraction versus conventional, which is going to be very, very interesting. This is something that we've started doing and we think it's the way to go. So please come to that 6th of November at 6 p.m. UK time. And then the month after, we have our colleague Amira from the US, who's going to talk to us about the MetroFERT study. Thank you very much for attending, and thank you very much for everyone who took part in presenting, Flo, Avril, and the rest of the team. Okay, good night.